This is Zachary Crawford with Pharm EDU, here to review 30S protein synthesis inhibitors. In terms of bacterial protein synthesis, the 30S and the 50S ribosome subunits come together to create the 70S ribosomal mRNA complex. Now, mRNA provides the information for the amino acid chain. In the nucleus, the DNA is transcribed into mRNA. That mRNA then brings the prescription of how the protein is going to be made to the ribosome, which is then translated into the amino acid sequence. At the ribosome, a charged tRNA brings amino acids into the ribosome to add to the amino acid chain. The ribosome will then add a new amino acid to the amino acid chain based on what mRNA code there is. In terms of protein synthesis inhibitors, you have the 50S inhibition and the 30S inhibition. For this discussion, we'll focus on the 30S inhibition. These agents include aminoglycosides, tetracyclines, and tetracycline. The three aminoglycosides are Gentamicin, Tobramycin, and Amikacin. They work by binding to the 30S ribosomal subunit to interfere with protein synthesis. These agents are concentration dependent. This allows for a significant post-antibiotic effect, which means there is a continued suppression of bacterial growth after the antibiotic levels fall below the MIC or the minimal inhibitory concentration. Extended interval dosing allows for higher peaks, which can be at least 10 times the MIC, and then wash out afterwards, which means there's going to be a limitation in the amount of side effects and also reducing costs. The effectiveness of these agents is based on the concentration above the MIC compared to the time above the MIC, which are time-dependent antibiotics. In terms of the spectrum of activity of aminoglycosides, they're mainly going to work on gram-negative bacteria. They will have Pseudomonas coverage. Gentamicin and streptomycin together can be utilized for synergy with gram-positive cocci, particularly for Streptococcus and Enterococcus. Aminoglycosides can also be combined with a beta-lactam or vancomycin for the same reason, and this here is typically used for endocarditis. In terms of route of administration, Gentamicin, Tobramycin, Amikacin can all be administered in multiple different ways. Gentamicin can be given IV and IM, but also has ophthalmic and topical formulations as well. Tobramycin can be IV, IM, ophthalmic, and inhaled. The inhaled tobramycin is specifically used for cystic fibrosis. Amikacin is available IV and IM, and streptomycin is available IM only. For dosing, aminoglycosides are dosed on weight base. So you would use the actual body weight if the patient is underweight, the ideal body weight if they are not obese or underweight, and then an adjusted body weight if they are obese. You will then use the targeted MIC of the bacteria, as well as the dosing interval and weight to come up with a dose. Side effects include nephrotoxicity, which is through acute tubular necrosis, ototoxicity, and vestibulotoxicity. Black box warnings include nephrotoxicity, ototoxicity, neuromuscular blockade, and respiratory paralysis. Warnings include caution advised in patients with renal impairment due to that nephrotoxicity, patients who are elderly as they would be higher risk for ototoxicity and nephrotoxicity, as well as combination with other nephrotoxic drugs. So to quickly review aminoglycosides, they are Gentamicin, Tobramycin, and Amikacin. They bind to the 30S ribosome to inhibit bacterial protein synthesis. They mainly have gram-negative coverage, but they can be used in synergy with other gram-positive agents to cover gram-positive bacteria. They can cause nephrotoxicity and ototoxicity, and they are concentration-dependent kill. Moving on to tetracyclines, these are also going to bind to the 30S ribosomal subunit to inhibit protein synthesis. These agents are Doxycycline, Minocycline, and tetracycline. Their coverage is going to be more so towards gram-positive bacteria, your Staphylococci, Streptococci, Enterococci, and Nocardia. They also cover some Bacillus and Propionibacterium as well. They do have some gram-negative bacteria, including the respiratory flora of Haemophilus, Moraxella, and some additional atypicals. Some unique pathogens, though, that tetracyclines do cover that you want to keep in mind are spirochetes, rickettsia, Bacillus anthracis, and Treponema pallidum. Getting into the specifics of the tetracyclines, one of them is doxycycline, which is available orally and IV. It's going to be first line for Lyme disease, Rocky Mountain spotted fever, as well as can be used for community-acquired pneumonia, as well as monotherapy for chlamydia and a combo therapy for gonorrhea. Minocycline is available orally and IV and is generally used for dermatologic indications, and tetracycline is available orally and is used in H. pylori treatment. The IV to PO conversion is 1:1 for doxycycline and minocycline. Some warnings include children who are less than 8, pregnant women, or those who are breastfeeding should avoid tetracyclines, as this can suppress bone growth, permanently discolor teeth, and impairs skeletal development. Other warnings include photosensitivity and hyperpigmentation, DRESS, and GI distress. Side effects include nausea, vomiting, diarrhea, and you want to make sure you take with food to limit gastritis and GI upset. Drug interactions are going to be focused around combination with other cations, which can limit the absorption of the tetracycline. These include antacids, those containing magnesium, aluminum, and calcium, sucralfate, bile acid resins, bismuth salicylate. So you want to make sure you separate the dose of tetracycline around any other drug that would be a cation. So you want to take the tetracycline 1 to 2 hours before or 4 hours after, and you also want to avoid dairy within 1 hour before or 2 hours after the tetracycline. Tetracycline is a 3A4 substrate and inhibitor, so you want to use caution with other 3A4 substrates, inhibitors, or inducers. One of the most significant ones is warfarin. Lastly, transitioning over to tigecycline. Tigecycline also binds to the 30S ribosomal subunit to inhibit protein synthesis. Tigecycline is technically in the glycyl cyclocycline class, which is then structurally similar to tetracyclines. Tigecycline has very broad coverage, including gram-positive bacteria of MRSA and VRE, as well as gram-negative coverage, with the exception of it does not cover Pseudomonas, Proteus, and Providencia. It also does cover some atypicals and anaerobics. It's indicated for complicated skin and soft tissue infections, intra-abdominal infections, and community-acquired pneumonia. Tigecycline is available via injection only. It does have a black box warning for increased risk of death, so you want to use only when alternative agents are not appropriate. Warnings do include hepatotoxicity, pancreatitis, photosensitivity, as well as teeth discoloration. You do not want to use it in bloodstream infections or patients who are in sepsis. This is because you have inadequate blood concentrations as the agent is very lipophilic. There is no adjustment in renal impairment, but there is dose adjustment in severe hepatic impairment. Side effects include nausea, vomiting, diarrhea, SJS, as well as an increase in liver function tests. And this concludes 30S ribosomal inhibition agents.